welcome everyone. We appreciate you guys coming in, like Ryan said, on this Sunday, giving up an hour or so of your time to listen to us and chat with us. We're going to be talking about kind of the concept of rethinking proximal stability for distal mobility. I think that's a really kind of accepted and applied concept in the fields of both rehab and movement. And today what we want to talk about is not that that's necessarily wrong, but maybe that it shouldn't be the end all be all, and what other lens can we start to think about more about what we and Ryan say is more of a distal stability for proximal adaptability, and how those two can really play off each other, kind of when one is appropriate versus the other. This is a really popular topic, I think, out of the roundtables that we've done. This has had the most signups. We had like close to 300 signups, I think, for people who are wanting to watch on the replay. So I think it's something that resonates with people. So we're going to try to dive into that. We did have a lot of new emails signed up. So for people who don't know us, my name's Dr. Kyle Paxton. You see Dr. Ryan Foley here as well. We're both the co-founders of Integrated Kinetic Neurology, or IKN, as a lot of people call us. Just kind of briefly, we started IKN in 2018. Our first course was March 2018. So we're coming up in a couple months here on our 3-year anniversary. But really, we started IKN because we saw how neurology was taught in kind of traditional physiotherapy school. We both are physical therapists trained very traditionally, and saw how neurology and neuroscience is really catered towards the idea that it should only be utilized in neurological populations, right? People with strokes, Parkinson's, etc. And I think we all understand that each human has a nervous system, and we wanted to teach you not just how to look at neurology through a slightly different lens for kind of more global movement and musculoskeletal conditions, but also to learn and really dive a little bit deeper into how neurology leverages the anatomy, and kind of bridging that gap between neuroscience and anatomy, because I think they're just inherently separated in people's heads. And a lot of people are high level experts in mechanics, biomechanics, and anatomy, and they kind of just push neurology to the side. And when you can start to understand how they're constantly interacting with everything that we do, you can really start to make some huge change. So that's why we created IKN, and that's why you see the majority of what we do be movement based for the most part, kind of talking about how you can leverage those two together. So like I said, today we're going to dive into that concept of rethinking proximal stability for distal mobility. And I think one of the biggest pieces of that, and maybe this is what we can start with, is really what is proximal stability, and why does this concept inherently think that we need stability in a certain area or stiffness in a certain area to have mobility in another area? Because I think maybe one of the things that Ryan wants to start with is looking at how we're actually built and understanding how our brain is actually configured to use our anatomy. You can start to think automatically very differently about how certain areas of the body should work. So maybe that's a good jumping off point, Ryan, if that's where you want to start.
Absolutely. Before we get started, there's one person whose mic is on, Alan Corby. I'm not sure why I can't mute your mic there. Should I mute all and then unmute you, Kyle?
Yeah, sure, that's fine.
Yeah.
And then just unmute me.
Still showing up that he's...
Alan, we might have to kick you out for a second. Just click back on the link to rejoin.
He's still connecting, that's why. Okay, that's fair enough. We'll give him a chance. Okay, let's jump in straight ahead then. Guys, I'm going to share a screen here with just an image of our skeleton, just to give us a representation of the configuration of our kinematics, but also above you're going to see representation of part of a nervous system called the cerebellum. Now we use for a lot of you that don't know what the cerebellum is below the cortex, it's subcortical, but it's one of the most important regions from a movement coordination standpoint, because it's actually the portion of the brain. It's a very small portion of the nervous system as a whole. It takes up 10% of the volume, but also it needs 50% of the overall energy from our nervous system. It makes up 50% of all the neurons across our nervous system. So it's a very, very busy area within a nervous system. Okay. Now, anybody out there who works with neurological cases, people like stroke or with stroke, or individuals with poor movement coordination, you'll find that people who suffer from a cortical stroke or cortex stroke will have trouble generating movement. They'll have trouble producing movement, right? Because the cortex is the part of the nervous system that produces movement, whereas the cerebellum doesn't have the capacity to actually produce motor output. But what it does is it refines motor output from the cortex, right? It smoothens out motor output from the cortex. And the cerebellum is the part of our nervous system that is always aware of every single portion of our anatomy. So it's constantly aware of things, compared to our cortex, the highest part of our nervous system, which does not have the capacity to be always aware of every single part of your body. So as you're sitting there now, or if you're standing, you're not consciously aware of your feet. You're not consciously aware of your pelvis. You are now because I mentioned it, but you're not consciously aware of it. Whereas your cerebellum is always aware of these things. It's always checking in. It's always being updated about the moment-to-moment state of your system. So this basically estimates the state of your system's ability to maintain its health. Okay. Now, for us, a lot of us that have gone through university, we learn about this kind of proximal stability for distal mobility, and it's really pushed through a lens of force production. The biggest thing to understand is that if you're trying to organize your thoughts about what movement is and how someone controls movement, you need to understand what are the control strategies that the individual is actually using. Are they producing movement? Or are they trying to attenuate? Are they trying to yield forces? Are they trying to decelerate forces? Right. This is the big thing that we feel as though people don't recognize enough when they're both assessing and actually then trying to prescribe certain types of interventions. You need to understand at what points do you need to bias more force production, at what points you need to bias more force deceleration, right? And the whole idea of proximal stability for distal mobility has been driven or underpinned by this idea of force production, because if I'm producing force, typically I'm producing force through my limbs. And if I'm producing lots of force through my limbs, I typically want a nice stable platform. I don't want an awful lot of variability around my midline, right? That makes sense. If I'm a powerlifter and I'm trying to lift lots of weight off the ground, I don't want a lot of movement variability around my spine, because that's going to take away from my conscious energy to try and overcome forces. So when you're trying to overcome forces, you obviously want less variability, because variability means there's more movement options in our system. So, but if you have more movement options and you're lifting 600, 700 pounds off the ground, that's very destabilizing. That's not stabilizing. So if you're bringing about variability throughout the midline, when you're producing force, then it can be destabilizing. So in that context, we do want somebody to perhaps express more stiffening around their midline to allow us to overcome forces. But if I'm an individual that just wants to get to locomote, to go from point A to point B in the real world, if I want to move through the real world environment, a very dynamic environment with lots of uncertainty, lots of unpredictable forces, if I'm not allowing for that variability around my midline, then that's not going to allow for a very adaptable movement system to be able to handle unpredictable forces and uncertain forces acting on my system. Okay, and so that's basically the platform for proximal stability for distal mobility. But like I said, if we're looking at things from a force deceleration standpoint, we have to recognize that the control strategies have to be very, very different. And the organization, you can say, of our movement apparatus, and obviously we're using the bones to represent this, and you can superimpose the muscles on top, and we'll talk about the organization of our muscular system too. But too often people forget that we have a top-down line of communication from the nervous system above that will take advantage of the properties of the kinematics and of the muscular system, and too often people forget about this. Okay, so if we look at the kinematics for just a moment, and we look at things from a joint structure standpoint, when we look at the center of the system, the midline of our body, because we can separate things into the midline, the upper limb, and the lower limb. when you look at the midline of our body, you see a lot of, not a very big distance between joints throughout our spine, not a very big distance between the ribs, right? And the short distance between joints, it's there for a reason. It allows for the sharing of load across those kinematic structures. It allows for a sharing of stress, a distribution of workload across the midline. So there's a huge amount of movement options distributed amongst the midline, okay? And if we superimpose then the nervous system on top of this, if we look at the cerebellum, for example, the cerebellum is functionally organized as well. And we spoke about the cerebellum being that structure, that part of the nervous system that's always receiving information from our anatomy, from our muscles, from our joints. The midline of the cerebellum, otherwise known as your vermis, regulates midline structures. It regulates midline tissues. So your rib cage, your spine, your pelvis, your cranium, your eyes, your vestibular system, your jaw, all these midline structures. But when you look at the midline of the cerebellum as well, the midline of the cerebellum does not communicate. If I have the cortex up here at the very top of the page, the midline of the cerebellum does not communicate with the cortex as much as the lateral portions of the cerebellum does. So the midline cerebellum is more subconscious in its movement control strategies, which means that the midline of their body should be more subconscious in the way it actually allows for movement to be controlled. Meaning, when I'm moving, I should not have a lot of conscious control distributed throughout my midline. If I'm just trying to do day-to-day things, I shouldn't be thinking about bracing my core. I shouldn't be thinking about what my rib cage is doing. I shouldn't be thinking about what my neck's doing. I shouldn't be thinking about what my shoulder is doing, or even what my pelvis is doing. As we move from the center outward, from the midline laterally, we have the intermediate zone on either side of the central zone. And the intermediate zone of the cerebellum will regulate the feedback from proximal tissues, so from your shoulder, your elbow, your hips, and your knees. And then as we move lateral, the lateral portion of the cerebellum will regulate the feedback from the distal portions of our body, our wrists, our hands, our ankles, our feet. And now the distal portion of or the lateral portion, I should say, of the cerebellum communicates much more so with the cortex. The cortex is more conscious in its control. It wants to think about what's happening. So from a neurological standpoint, that means for us that the higher portions of the central nervous system will distribute more conscious control through the distal parts of our body. And that makes sense because when you think of it from a load standpoint, what portions of this skeleton here is actually in direct contact with our environment? Is it the head? Is it the shoulder? Is it the rib cage? Is it the pelvis? No, it's the distal segments of our limbs. The hands and the feet are the structures that are actually in direct contact with our environment. You don't see many people picking up their coffee cups with their elbows or running down the street on their knees, right? And this represents how the central nervous system has exploited, you can say, or has leveraged its interaction with our skeleton, our anatomy, to make it easier to control this mass, this system. Okay, and that's very, very important because there's a huge number of movement options across the midline. So imagine if we had to consciously think about all those little movement options, if we had to consciously control each direction that a vertebrae could move in, if we had to consciously control all the movement options around the pelvis and the hip and even the shoulder. So as we move from central to lateral, and as we move from proximal to distal, we move from more subconscious bias control to more consciously biased control. And so we'll talk later on in the video, this talk about what this means from a rehabilitation standpoint, because that's probably why we're all here, to understand how did this fit into an assessment and a rehabilitation context. If I have somebody in front of me with back pain, how does this fit into this communication between top down and bottom up lines of communication? So it's number one, you just have to understand that the cerebellum, which is always aware of our anatomy, it refines movement output. So if I had a problem with my cerebellum, for example, I would be able to still move, but my movement would be very, very uncoordinated. That's the key understanding there. If I have a problem with my cortex, I'm probably not going to be able to move because I don't have the ability to produce motor output. But if I have an issue with my cerebellum, I would still be able to move, but it's not going to be as refined. It's not going to be as smooth, my movements. So the cerebellum is key for allowing for a distribution of workload amongst different portions of our anatomy, but it's also key for allowing for efficient movement control in the real world, right? In how it biases its regulation of different portions of our anatomy. Okay, now understanding this from a system standpoint, how then might we go about organizing control throughout the midline if I can't consciously think about how to control my midline? If I can't consciously, Kyle, actually, I'm actually just going to go back there and just check to see. I'm going to stop this just to make sure that nobody's trying to get in. Okay, yeah, nobody's trying to get in. If we understand this from a control standpoint, whereby if I can't consciously think about what's happening at my midline when I'm walking down the street, when I'm walking around my house, when I'm walking in maybe another uncertain environment, if I'm an athlete and I'm running on a soccer field, then what allows for control throughout this midline portion? Well, the way in which the skeleton has been organized, allowing for this short distance between joints, it gives you an insight into how that happens, because that allows for a distribution of workload amongst many, many joints, because again, there's a very short distance. So there's a sharing of workload amongst these midline structures in how it has been organized. So the feedback from the skeleton, feedback from the tissues is extremely important. When you think of the rib cage, for example, again, we breathe 20,000 times plus per day. So the movement of air into our system is constantly allowing for that expansion of the rib cage and a compression of the rib cage. And when I expand my rib cage, that's going to load certain tissues around my rib cage as well, which is going to constantly feed back information to my nervous system about the state of my body, about the state of my midline in particular. Okay. Thirdly, so that's one. So number one, we have to have good quality feedback from the anatomy. We have to have good quality breath coordination through the movement of air in and out of my rib cage, which allows for the loading of tissues surrounding the rib cage. We also need to have good lines of communication from the eyes, from the vestibular system. So when my head moves, that's going to allow my vestibular system in my inner ear to turn that head movement into information that my nervous system can use to know where I am relative to gravity. Okay, so head movement is key to allowing for reflexive changes in tone, particularly throughout my extensor tissues. And obviously the eyes will help guide what needs to happen throughout the body too. But one key quality that people don't talk an awful lot about is the importance of the limbs to be able to express what we would call a force dampening quality. Because the limbs, and particularly the hands and the feet, the endpoint segments of the limb are in direct control of the environment, we need them to be able to handle load in a distal to proximal fashion, from the hand proximally, from the foot proximally, to ensure that this area here, the midline, does not have to express any kind of stiffening strategies. Okay, we want the limb to express qualities to allow us to dampen stress, so that the midline ultimately doesn't have to. Okay, and this is ultimately kind of the main point that we want to try and get across to people, in the sense that we actually want the distal tissues to express good force dampening qualities, not to be stiff per se, not to have a lack of mobility, but to express certain features to be able to handle stresses well from distal to proximal, so that we can ultimately allow for the midline to be nice and adaptable. And again, you see this in the research an awful lot. Again, all you have to do is reach out to us and ask us for these different papers that we can send to you. One of the most common things you're going to see, if somebody sprains their ankle, for example, or if somebody has chronic ankle instability, if you think of the ankle, it's very important because it has to manage a lot of mass proximally, right? So that's a huge amount of mass and movement options that are available to us around the midline, around the limbs, and even through the proximal lower limb. The ankle has to be able to manage all of that. So we have to express good quality ankle strategies. So I need to allow for good quality responsiveness and dynamic stiffness in the foot and the ankle. If I don't allow for that, what you'll see in the research an awful lot is that an individual will shift to using more of a hip strategy and a low back stiffening strategy, or just a spinal stiffening strategy, because that freezes the degrees of freedom, that freezes the movement potential of my spine, which in the short term, makes it very easy for my nervous system to control my body now, because now I don't have to worry about all this extra movement possibility at the midline. So it actually makes it easier for our system to manage our mass when I actually tighten up or stiffen up all the tissues around my midline. But that might be good in the short term, but for you to be adaptable in the real world, for you to be able to move through the environment in a very dynamic fashion, that's not a good strategy to use, okay? So we need to recognize that, and we'll talk about them in a few moments, that the limb expresses certain features to allow us to dampen stress acting from distal to proximal, because load from our environment, the environment's acting on the hand through here. So we need to handle that stress from distal to proximal, so that here doesn't need to tighten up. What do you see an awful lot in the research in individuals with excessive activity around the upper trapezius, for example, or the SCM? You see that when they go to move their upper limb towards a target of interest, you see excessive activity around these proximal tissues. And then you have to step back and ask yourself, well, why is that? Potentially, when I go to move my upper limb towards the target of interest, if my nervous system doesn't trust the limb's ability to manage stress from distal to proximal, then what do you think it's going to do? It's probably going to freeze the movement potential at the midline, because there's a lot of important stuff in here. We have to agree that within your rib cage, there's a lot of important things. The midline is where all our, you can say, all the tissues and the structures that keep our body alive are present, right? And to put it extremely crudely, if I was to cut off your upper limb here, right? If I was just to cut it off, there's still a chance that you might be able to stay alive as long as you get to the hospital quickly, right? But if I was to cut you through the center of your body, there's going to be less of a chance that you're going to stay alive, because this is, the midline is the portion of your body that keeps you alive, whereas your limbs are the portions of your body that allow you to, not to thrive per se, but to allow you to manage stress and make your system, allow your nervous system to have an easier time controlling your mass as you move through a very dynamic and a very uncertain environment, right? So we're thinking very, very big picture here, right? And that's key. You have to think big picture, right? Carl, do you want to add anything to that?
Yeah. I think as you go through all of that, and like I said, I know a lot of people watching this are relatively new to what we try to push as concepts, but we're not making things up, right? When you look at how our body and our nervous system has developed itself over tens of thousands of years, you can start to build the way you're driving your interventions around how we've naturally been moving, right? And like Ryan just went through and spoke about our control strategies. We just talked about how most of the things proximally through that midline are really meant to be more subconsciously controlled, right? But if we're talking about this proximal stability for distal mobility, I see it applied many times for people who have like shoulder or hip tightness, right? What they do is they try to build hip or shoulder stability or core stability, and they use these stiffening strategies to build more stability, right? Conscious stiffening strategies, right? Say we're trying to improve shoulder stability. What do? They give you endless amount of retraction exercises, right? Consciously squeezing these shoulder blades, consciously squeezing these glutes, consciously squeezing the core to help improve stability, which they're trying to accomplish mobility in some of those other joints. But understanding some of these control strategies, like Ryan said, starts to flip that, because really it doesn't make sense to give you more stiffening, tightening strategies if we start to understand that part of the reason why that kind of proximal joint or midline is probably tight in the first place is because your brain doesn't trust your limb's ability to dampen the force, right? So the midline and proximal structures have to tighten to help that, right? So even some of the things that we just kind of take for granted that you see all the time, all these constant retraction, conscious glute squeezing, shoulder blade exercises don't really make a lot of sense in the long term, right? And this starts to talk about, maybe this is a good bridge into that. When are some of those strategies okay, and when are they important, right? I think we understand in some of those acute strategies, because Ryan just said feedback from these midline proximal structures is important. And likely that's what you're driving with some of these kind of conscious strategies, right? It's not a long-term solution, but I think we all know that it can be helpful at certain points, right? Because we've seen it be helpful. It wouldn't be repeated if there wasn't some small benefit to it. But the shift isn't necessarily what are you doing on the table to open up small windows or bring down pain temporarily. It's if we want our clients to be robust and be able to move up against gravity in these uncertain environments, what strategies we have to start to leverage. And that's where kind of this separation of understanding the control mechanisms of the midline versus the limb and how you should be leveraging your interventions really starts to make a huge difference. Because yes, when you squeeze your core or do some retraction exercises, do you get some changes in mobility elsewhere in the body? Yeah, right. Because you're driving a lot of feedback from those tissues. So your body's going to have a little bit better idea of where you are in space, but that doesn't last, right? This is the reason why people have to keep coming in and figuring out what the next steps are, because for the most part, we're driving our interventions through local feedback strategies. And this is, again, like Ryan just said, trying to get you to think bigger picture about why some of those strategies are there in the first place. So, Ryan, do you have an opinion on why or when maybe some of these kind of proximal strategies should be utilized? I mean, in general, like I think, especially if we're talking about pain, when people are in really high levels of pain, I use it initially just to drive some feedback from that area to just get the body to have a better idea and calm down a little bit. And then once we start kind of progressing past that really basic initial entry point, I start to flip to more of this kind of distal to proximal strategy. What's your thought on that?
Yeah, like we mentioned initially, like, well, partially when this might be important when you're trying to produce lots of force. Right? Yeah. If you're trying to produce lots of force, again, it makes sense that I want to stiffen my midline because there's so many movement options there. If I'm trying to lift heavy weight off the ground, I don't want a lot of movement options because that's going to take away from my conscious resources to try and lift as much and get as much leverage as I can to lift that weight off the ground if it's a deadlift. So it makes sense that I want to stiffen things up through here. But again, like I said, to move through the world and be able to express robust movement qualities and manage stressors well, we shouldn't have to produce lots of force. Again, when you look into the research and you look at it from a maximal voluntary isometric contraction standpoint, how much force do we actually need to distribute through tissues to be able to move through the real world? And we really only need 30% of our maximal voluntary contraction capabilities. We don't need to produce 100% of our force through our tissues to be able to walk down the street. So real world movement is not about force production. It's about recognizing that there's always stress acting on your system from a moment to moment standpoint. And what we have to step back and understand, well, what's this constant source of stress? And that constant source of stress is gravity. Gravity is always trying to pull you down to the ground. It's always trying to put length into your tissues. And so you have to step back and understand, well, there's two ways I can actually manage gravity. I can fight it by producing force against it. So maybe I might extend my spine. I might put a lot of tone into my spinal extensors, which would limit the variability at my spine, which makes it easier to control, but it doesn't allow me to be adaptable. Or I can attenuate that gravity. I can yield gravity, right? So in order to yield gravity, we need to allow the limbs to manage the stress, which will create an environment for the midline to maintain adaptability, to maintain some kind of variability. But it's not just a case of just throwing variability at the system. We need to know, where does the system need variability, but where does it need to express qualities that manage stress? Because you need to manage stress to be able to allow for variability. This is another key finding in the research, is that when your system is under stress, one of the first things that it will do is it will freeze the degrees of freedom, particularly at your spine. It will limit the movement possibilities, because if I'm under stress and I'm putting all my resources into managing that stress, I don't want lots of movement options at my body for me to have to handle, because that just takes more energy. And that's pulling away from my resource pool to manage other stressors. So just to reduce your movement options is a strategy, is a protective strategy that the nervous system will use to help you manage other stressors. Okay?
Quickly, right? I think this may be helpful for some people who especially work with this population, because I think what we've said so far is dependent on your goal, right, may depend on what type of strategy you're using. And you've used the example of people who are lifting tons of weight, right? It is certainly beneficial in a force production strategy to utilize some of those conscious proximal stability interventions and kind of reinforcing that, et cetera, to allow them to accomplish their goal. I treat a lot of powerlifters. So I have a chain of outpatient practices here in the DC metro area. And one of our locations is in a powerlifting gym. So I work with a ton of people who are utilizing that strategy all the time. And I think part of the problem they run into is, yes, to accomplish their goal and be better at their sport or get stronger to lift those really, really heavy weights, yes, you need that strategy. But when you're constantly just reinforcing that strategy over and over, they carry that strategy into the rest of their lives, right? They carry this kind of proximal stiffening strategy into everything they do on a day-to-day basis. And most of my powerlifters, they don't get hurt under the bar when they're lifting that weight, right? They don't have the issues there because their movement strategies are allowing them to accomplish that very successfully. What they come in and see me for is maybe they have this kind of building low back tightness, like Ryan just said, through that erectors, or they have an issue when they have to just kind of bend and twist to go pick up their sock because they are carrying these proximal stiffening strategies into everything else they do. So even if you have someone whose goal is force production, I like to use this flipped kind of distal to proximal lens because we know that's what they need in the real world. I have them do it drills that we can talk about briefly here in a second of how to leverage some of these things. I have them do these types of things that look through this lens after they're done with their exercises that use these conscious proximal stiffening strategies, almost as an idea saying, okay, hey, we're leaving this artificial environment and this inefficient environment. We want them to go back out into the real world. And there's still tons of value in doing that, even if their goal is force production. Because they're under a bar for 1% of their life, right? They need to be able to move efficiently the rest of their life. And they don't want to carry these inefficient real world strategies into what else they do. So I think that's an important thing to understand, especially when we're talking about when their goals are either force production or kind of real world stuff. Even if their goals are high level force production, this stuff is critical to make sure they can keep sustainable strategies under the bar and not get injured outside of the bar. Because I think anyone who treats that type of population understands that that's where most of it's happening. So again, just like anything else, you need to understand what you're trying to accomplish with the person in front of you, right? Everyone has unique movement goals. And this is just a lens that most people tend to miss, right? Most people don't think distal to proximal because whether they're, and maybe this is something you want to touch on, Ryan, of why this is important, but like a lot of people go off this developmental strategy that as babies, we kind of started with proximal stability and then started moving in our extremities, which is where a lot of that thought process comes from. But as soon as we get up and start moving against gravity as coordinated adults, that control strategy switches, right? And you can see that in the neurology. And I think that's such a critical thing to understand that most providers miss at this current point in time.
Yeah, it's about recognizing the environmental effect on your body too, like how the environment changes the strategies you want to use. If you're in a gym setting, and you're trying to lift a barbell off the ground, you're not in a very chaotic environment. You're not in a very unstable environment, right? Whereas when you're in the real world, you're crossing the street, you're walking down the street, you have to move around people, you have to maybe move in a rough terrain. If I'm using those same strategies in that environment, I'm going to be less adaptable, and I'm probably going to use very unsustainable strategies, and that's going to eat into my resource capacity to manage stress. But you made an important point there as well, is that a lot of these proximal stability for distal mobility, these thought processes have developed from neural development. Because when you're a baby and you come out of your mother's womb for the first time, for 9 months prior, you've been living in an aquatic environment. You're basically a fish coming out of your mother's womb, right? So you're basically a fish coming out into a gravity-driven environment. So that's why you just don't pop out and start walking around. You have to slowly develop the ability to get up on 2 feet and start interacting with the world in a much more complex way. So a baby will develop from proximal to distal. So they'll have to use their eyes, they'll have to control their head first, control their spine, then slowly get up onto 2 feet, and then all of a sudden they can start going up to the kitchen table and grabbing that cookie, grabbing that piece of candy for the first time instead of having someone give it to them. So they start shifting their control strategies from more of a proximal to distal strategy to more of a distal to proximal strategy, because now they're organizing their movements around what their limbs are going after, how the foot is managing pressure and load from distal to proximal, and how the hand is organizing its movements to reach for targets of interest, right? And so I think it's helpful to talk about what this means from a pain standpoint as well before we finish up, because I can use an example that I had and that I have in clinic all the time: people with low back pain, right? If you look into the research around low back pain, you're obviously going to find that there's no uniform muscle activity pattern when it comes to people that express low back pain. But you will find commonalities across certain research papers as well. And the most common one is that if somebody has low back pain, or those with low back pain, when they move their limbs, they tend to have a delayed activation of their local stabilizing systems, or the local stabilizing muscles, like your multifidi, like your transversus abdominis. Okay. Now, we're not disputing that, but then you have to step back and especially when you look at things from a neural and an anatomical lens, you have to step back and understand, well, why are those local tissues expressing delayed activation? Because what researchers and what therapists have done by looking at those research papers is said, okay, the transversus abdominis, the multifidi, express delayed activation when people that have low back pain. So I need to get the transversus abdominis and I need to get the multifidi firing again, right? But if you recognize the neurological bias of control towards certain tissues, you have to recognize that you don't have conscious awareness or conscious access to fire your transversus abdominis. You don't have conscious access to your multifidi. You can't feel your multifidi around L4, L5. You just don't have conscious access to that. So those tissues are actually, the control strategies for those tissues bias more of a feed forward activity. Because when I reach my limbs towards a direction of movement, there should be increased activity in those tissues even before I start to move my limbs. And then you have to step back and understand, well, what's the function of feed forward control? Feed forward control is a predictable expression of muscle activity to reduce disturbances on your system. So it's protective in nature. But if somebody has delayed activation at the midline tissues from a feed forward standpoint when they move their limbs, what we, from an IKN perspective, would take from that is their nervous system doesn't trust the capacity of the limbs to handle stress well. And what you also see in the research is that they have delayed activation of the local stabilizing muscles, but they have greater activation, greater muscle activity of the more superficial tissues, like your rectus abdominis, like your erector spinae. So they lose the ability to allow for ideal muscle activity of the deep tissues, but they have greater muscle activity of the superficial tissues, which you do have conscious access to. So you can think of it as this. In low back pain, this is how I think when I have a client in front of me. I think of that as there's a disruption in the control gradient from distal to proximal. Because when we look at somebody with low back pain, and obviously there's so many other factors to consider here instead of just the neural control of our anatomy, there's obviously other psycho-emotional factors we have to consider as well. But if we're looking at things from purely a neuroanatomical lens, if I have a pain experience in my lower back, we have to consider what pain is from a big picture standpoint. Is pain more of a subconscious experience or is it a conscious experience? Pain is a conscious experience, right? It's a protective output to change your behavior or to communicate to you that something is not wrong necessarily, but something requires extra protection for. Your brain perceives some kind of threat to your system, so it's expressing pain as a protective strategy to change your behavior in some way. But if I have more conscious control here, think back to what we said originally. Do I want more conscious control here when I'm moving through the world and I'm trying to be robust and I'm trying to be adaptable and I'm trying to share workload across systems? No, I don't. I don't want to be thinking about my lower back when I'm walking down the street. I want my nervous system to distribute conscious control around the foot. So if somebody has a pain experience around the lower back, or they have increased tension around the lower back that they're consciously aware of, think of that as a disruption to the neuroanatomical gradient from distal to proximal, where I have less conscious control here now around the foot and more conscious control around the lower back. So from a big picture standpoint, a large part of our assessment and rehabilitative process is to try and restore that neuroanatomical gradient, to try and shift conscious workload here to here. but we need to recognize that obviously every single individual is unique. Now we have to also think of it from a best case scenario. Best case scenario for an individual with low back pain is proving to their nervous system that we have the capacity to handle stress from distal to proximal through the limbs. Okay, so very, very early on in treatment, we might try and distribute some workload into the limbs while trying to allow for these tissues to unload any kind of excessive protective tone, or what we would call the suspension of anti-gravity function. Can we allow these tissues to relax while these tissues express more force dampening qualities, while these tissues can handle stress more so? Because when you look at the orientation of my limb, for example, look how much there is of a distance between my hip and my knee compared to the L4 vertebrae and L5 vertebrae. There's a much larger distance between those joints. And that's why I'm equipped with certain tissues to be able to handle stress. That's why you have more biarticular tissues in your limbs. And when you look into the research around biarticular tissues are seen as your first responders to stress. They allow for transportation of energy from between joints that are far apart. They take on more what we call a preflexive role, in the sense that they don't need the nervous system to try and control them or micromanage them. They're able to handle stress on their own before the nervous system has to express any kind of, you can say, micromanaging role to think about what's happening there. Okay. I have clients almost every day like this, in the sense that if someone has low back pain, we have to understand what their past injury history is, what their past surgical history, their basically their past experiences. If I have an individual who has lower back pain, and they have no history of any kind of low back pain in the past, they don't have any past surgical history around the midline, for example, then in those situations, I may be able to move very quickly towards reestablishing that distal proximal load transmission, that distal to proximal load distribution, to allow for the limbs to handle stress and allow for these tissues to unload. Okay, because I don't have a long history of lower back pain. I had a client early last week with a lot of surgical history around the lumbar spine. Okay, initially, I'm sure you've seen videos of our treatment, our treatment framework, in the sense that initially we want to allow for good dissociation capabilities. And from a dissociation standpoint, what that means is essentially allowing for the limb to handle stress while encouraging the midline tissues to unload their anti-gravity function. Can they relax while the limb handles stress? In clients with that I found, and Kyle has found as well, that have a long history of lower back pain, that have potentially lots of past injuries around proximal tissues, they might not be as willing to let go of that conscious control around these midline tissues. So I will use a strategy where I have somebody in a supine position with their heels up on a chair and trying to slowly build tension into the limbs while allowing for the tissues, especially around the lumbar extensors, to unload their anti-gravity function. In clients that have a long history of low back pain, for example, or have lots of surgical histories or prior injuries at the midline as a whole, they might not be willing to allow for a distribution of load through here, to let go of here. So they may have increased tension around the lumbar spine when you try to do those distal to proximal dissociation strategies. So we have to recognize that those individuals, we may need to do more midline work with them initially. But the goal is to always get the distal tissues to handle stress and distribute that proximally, right? And in those clients, typically, you're going to see a lot of stiffening strategies, a lot of bracing strategies. And that's okay. I had a client last week who couldn't touch her toes without pain, but when I had her brace her spine, brace her core, brace her abdominals, she was able to touch them with much less pain. Now, some people might look at that and say, okay, she needs more core stability. But I look at that and say, okay, well, when she braces her abdominals, that limits the movement potential of my midline structures. That may reduce the threat of the nervous system where it doesn't feel the need to express much pain. But what I need to do now as an individual, as a therapist, is maybe provide higher quality information, higher quality feedback from the midline to allow for the central nervous system to feel comfortable with the midline's ability to handle stress, to share stress, so that I can ultimately allow for the limbs to take on more of a force dampening role. The goal is always to get the distal tissues to handle stress. But in certain clients, you may not be able to just jump straight into allowing for the limbs to handle stress from distal to proximal. You need to respect that sometimes we need to do more midline based strategies, whether it be working through breathing, whether it be allowing for better feedback through the midline tissues, whether it be allowing for better, and again, this might be later on in the rehab process, but allowing for better visual and vestibular interactions to allow for good communication, top-down muscle tone. But again, like I said, from a limb standpoint, we have to look at the lower limb and spine interaction. There is an interaction between the environment and the foot, but there's also interaction between the limb and the midline. We always want the limb to be able to dissociate from the midline. Sometimes you can use a strategy where you allow for the limb to handle stress from the bottom up, but oftentimes in clients with a long history of lower back issues or lots of prior injuries around the midline, you might have to do more midline focus work first. But again, it doesn't take away from this idea of moving towards more distal to proximal strategies. It's always the goal, because again, we have to recognize it from a neurological standpoint. Again, our nervous system will bias more conscious control through the distal endpoints. If I have a pain experience, particularly proximally, that's going to disrupt that gradient of conscious control, where I have more conscious control here, less here. So the endpoint goal is to always allow for the foot to be able to experience more conscious control, more load, and allow for that distribution of load proximally, so that these tissues can express variability, express adaptability.
Yeah, I think that's a great summary. And I think kind of to just start to tie some things together, one of the biggest takeaways from this, hopefully, is one of the things Ryan just said with that example of the woman who had pain or stiffness bending forward, but when they braced their core, she was able to do it more successfully, right? Whether it's more mobility or whether it's with less pain. I think that phenomenon is how this proximal stability for distal mobility concept has been continuing to be propelled. But it's a little bit of a farce, right? It's a little bit tricky. When you start to understand the neurological control, you realize that is a completely unsustainable strategy in the long run. And I think that's why a lot of people go through PT and have these short-term results, and then their pain or their tightness comes back 4 weeks later, right? Because now they're sent back out into the real world, and that strategy is just not sustainable in the uncertain environment. And that distinction should be your biggest takeaway from today, of what you're actually seeing may not truly mean what you need to continue to reinforce now that you understand some of these kind of bigger picture neurological control pieces. And I think maybe the last thing that we can touch on, and it kind of rolls in directly to one of the next things we're putting together. One of our favorite ways to leverage these distal to proximal strategies is through isometrics, because you can drive intention through certain areas of the body that you aren't normally, right? We can start to leverage some of these kind of more passive force dampening qualities that the biarticular muscles have. And that's something that we do a lot that I think is wildly underutilized, especially in the kind of early strategies to get people to flip their lens to this distal to proximal kind of concept. And that's something we're going to be trying to give you guys a lot more access to. I think certainly you guys have probably seen us post a lot of isometric pieces at this point. Before we say any more, though, I know we've kind of talked a lot and gone back and forth. Does anyone have any questions about that? I had posted in the chat to kind of ask questions as we go along, but now that we're at a little bit of a pause point, do you guys have any big questions about any of those concepts? Or does most of that start to make sense, right? This is really just a jumping off point. This is a concept to look at movement, and then your interventions can be as creative as you want it to be, as long as you're respecting the neurological control, right? There's no one way to perfectly leverage these things. We have some interventions and framework put together because we think it's kind of the easiest progression. But I think even as something as simple as like your cueing, like changing where you're driving your cues through, is something that you should start to think about maybe doing differently just from this discussion, right? Most cues tend to be proximal bracing, right? And now we're starting to maybe flip that gradient. All right, got a question here. How can we change increased proximal tone without hands-on techniques? I've heard you guys say breathing, but can you give some more examples? I think isometrics is probably one of the biggest ways we start to do that, and starting to leverage some of these distal biarticular tissues, because we talked about some of the kinematics, right? Talked about these really long tendons, these really long bones. Give your body a chance to utilize those structures. Once you can start to prove you have the control strategies over those structures, the brain will naturally pull away some of that protective tension proximally, right? Ryan, do you want to add on that? I mean, without going too deep into any interventions or anything, because we just have a couple minutes here, but.
Yeah. Like I use isometrics all the time, and I think it's worthwhile. Like, we've obviously spoken about the kinematics here more so than muscles, right? So, but one of the most common things I'll see in clinic and somebody has lower back pain is a lot of, I suppose, upper gluteal tension, right? In the classic kind of piriformis region that everyone always has. But if you recognize I suppose you can say the architecture of those proximal tissues versus distal tissues, when you look at the glute max, for example, you're not going to see an awful lot of tendinous tissue around the glute max. The glute max fibers are very, very long, right? They're in parallel. They're longer fibers. Longer fibers in the system are typically muscles that undergo a lot of lengthening and shortening, compared to when I look down at the gastrocnemius, for example, and I have a more of a pinnate structure or a pinnate orientation of the tissue, where the fibers orientate towards the tendon at an angle. Those aren't tissues that go through a lot of lengthening and shortening. So I need these distal tissues to experience more of an isometric function, because when my foot hits the ground, I don't want those tissues to go through a lot of lengthening and shortening, because that's not going to allow my system to respond very well to the impact, the collision from distal to proximal. So it's very, very often you're going to see these proximal tissues take on more protective tone when I've lost the isometric capacity of these distal tissues. And that's very, very common. Very, very common I see in clinic. And so if I have a more protective tone, you can say, up around my upper gluteal region, you can say, one of the things you're going to have to recognize is, well, okay, that's protective tone in a proximal tissue. Do I want a lot of protective tone around those tissues? If I have protective tone and I'm feeling it when I'm walking, okay, that's going to generate more conscious awareness around those tissues. So I want to start to allow for these tissues to express some kind of unloading, because the glute max is an anti-gravity tissue. It's going to keep you upright. So I need to allow for a suspension of these anti-gravity tissues. So I might want to shift a lot more of an isometric capacity into the hamstrings. But I need to do that from a bottom-up standpoint and a top-down standpoint. So I might utilize a position where I'm allowing for the hamstrings to take on more of an isometric role, but I'm also allowing from everything above the pelvis to take on more of an adaptable role. So if you think about it from a gravitational standpoint, if I want to fight gravity, and if I want to put a lot of extensor tone into my anti-gravity tissues around the erector spinae, around the glute max, for example, particularly the upper gluteal fibers, I'm going to fight gravity by extending my spine, right? So I'm going to increase you can say the concentric activity in those spinal extensor tissues, those anti-gravity tissues. So I think about what happens then from a rib cage standpoint. If I'm extending through my spine, my rib cage will begin to elevate. My rib cage elevates, my diaphragm will descend. So I might want to do some more rib cage adaptable activity to try and get my rib cage to come down. So I might work a lot on more exhalation biased activities while I bias more isometric activity of the tissues of my limb, particularly the biarticular tissues. Right? Because when I exhale, that's going to allow for my rib cage to depress, to come down. That will typically couple with my pelvis's ability to tilt posteriorly and allow for these lumbar extensors to suspend their anti-gravity role. We're not trying to fix, like if somebody comes to see you with an anterior pelvic tilt, for example, it's not that that's a bad thing, but step back and recognize, well, what does that mean from a gravity management standpoint? If somebody has an anterior pelvic tilt, does their nervous system actually trust the limbs to handle stress? Perhaps not, because when I move into more of an anterior pelvic tilt, I'm taking these spinal structures into more of a closed pack position. When they're in a closed pack position, I have less movement variability. When I have less movement variability here, that's going to allow for my system to control that easier, but that's not going to allow me to be adaptable. So I need to allow for these tissues to move towards more of a closed and open pack position, I should say. But at the same time, I need to do that whilst also improving the capacity of the limb tissues, particularly the biarticular tissues, to express a higher isometric activity. Because that's typically what the research tells us, that these biarticular tissues, how they operate in a real world movement scenario. These tissues will typically operate isometrically, because when tissues operate isometrically, it allows for a sharing of forces, a sharing of workload. If I'm putting an awful lot of concentric activity into a tissue, for example, that's not going to allow me to share workload. And that's why I can't handle as much force as I can concentrically compared to eccentrically or isometrically, because a concentric dynamic of movement it allows for more positive work, so it's energy expensive. So that's why allowing for the biarticular tissues to take on more of an isometric role while suspending the anti-gravity tissues proximally. But we can use a certain position, but what I tend to use is more the movement of the rib cage, not necessarily from a breathing standpoint, but the actual movement capacity of the rib cage to move in a certain direction, to allow for these tissues posteriorly to suspend their anti-gravity role, to allow to essentially force the nervous system to have to use these tissues isometrically. And that's one way. From a manual standpoint, again, manual input is just load into the system, just like any other exercise, right? We can obviously get a little bit more focus on what's going on locally. You can do manually driven isometric activities for the limbs as well. But really, when we're thinking big picture here now, just think of it from a proximal to distal standpoint. Can the proximal tissues unload their anti-gravity function? And their capacity to unload the anti-gravity function is necessary to then allow for the distal tissues to express more of a force dampening role. If I can't unload the anti-gravity function of my proximal tissues, it's going to be very, very difficult for the distal tissues to take on more of a force dampening role. All right.
Perfect. Yeah, great. Two more questions here. I think we'll cut it off at that. But one question from Tisha here. I'm assuming this is for general population of someone who does not have any neurological disorders such as hypotonia, or would this also apply to someone with something like that as well, who has a neuromuscular disorder of some kind?
Yeah, I think so. I treat a lot of clients with Parkinson's, with MS, and when you really consider what's happening there from a big picture standpoint, especially with Parkinson's, the neurology tells us that it's essentially the reliability of the proprioceptive feedback from the tissues of the body becomes less. The nervous system doesn't trust the input from the proprioceptive system. That's why we see this kind of the movement into a hunched over posture. So for those clients, I will do an awful lot of work with the rib cage, because I have to recognize the rib cage has to move 20,000 times plus per day. And the movement of air into the system is actually going to update my nervous system with an understanding of what's happening. But we would probably have to get a little bit deeper to really to really kind of talk about this and clear up any misconceptions. But there are different control strategies, and there's three essential control strategies your system will use to manage stress, to manage forces. One will be feedback, which is actually the feedback from your tissues. Think of it, when my foot hits the ground, then there's going to be certain levels of feedback or certain sources of feedback from the tissues of my foot and ankle to tell my brain what has just happened. Now, we have to recognize that a feedback control strategy is slow. There's a time delay for the feedback from my foot to reach my nervous system. So that type of control strategy isn't able to allow us on its own, isn't able to allow us to manage to the here and now, to the stress acting in my body. So we have another control strategy known as feed forward control, where when I'm moving through an environment, the feed forward control strategy will use past experiences to predict what's going to happen. So my nervous system will recognize that I'm walking, and it knows that my foot's going to hit the ground. So it'll actually increase the muscle activity, or it will create a pre-tension effect in the tissues of my lower extremity to manage the collision with the ground before my foot even hits the ground. So my muscles never react to the ground. My muscles never react to the joints. they're already responding to the movement of the limb from a feed-forward standpoint. And that's why you can never only give good feedback to the muscles and good feedback to the joints, because we have to operate off a predictive control strategy as well. But then we have a third control strategy, and that's the intrinsic properties of our system that actually do not need top-down control. And in neurological research, they will look at these as preflexive control strategies. Now, preflexive control strategies do not require top-down neurological control, right? And the geometry of our system, the geometry of the body, in the sense that we have lots more muscle mass proximally and much less muscle mass distally, much more tendinous tissue distally compared to proximally, is a preflexive quality, is a preflexive feature. Because when my foot hits the ground now, I can allow for those passive elements, those passive tissues, the tendinous tissues, to be able to quickly respond to load without needing the nervous system to produce a motor output to respond to that. So for clients with neuromuscular disorders, we have to get them better at exploiting the intrinsic control strategies that do not require a top-down control strategy, because the feedback control strategy, the feed-forward control strategy is affected from the neurological condition. So I will still use an awful lot of isometric strategies in a distal to proximal manner with those clients, and still use the breathing work with them as well. From a big picture standpoint, when someone presents with pain or more of an orthopedic condition, we might have to do lots more local work around the area of that's expressing protective tone. For example, like if someone has low back pain, maybe have to do some work around the hip, around the pelvis, to then allow for the support of these bigger picture qualities, like the limb to be able to handle stress and distal proximal. Right. So definitely would use the same strategies.
And then I think you almost started to answer kind of the last question here. What are your recommendations as using conscious strategies, like in the general population, like apart from weightlifters? Would you use them in like acute pain cases and work towards subconscious strategies as soon as possible? I think the biggest takeaway from this is we want to long-term always be working to these sustainable distal to proximal strategies, because that's how we're really meant to move in the real world. That being said, like Ryan gave the example of that client with the significant history in the low back pain or in their low back, right? Surgical history, et cetera. You may have to start with some conscious strategies there, whether that's kind of local feedback, hands-on work, or local feedback with some of those kind of conscious midline strategies that we're all so familiar with the idea that that is only a bridge to get them to start to tolerate the distal to proximal strategies. That is always our goal. And I think that's the biggest takeaway. And that's why we said from the beginning, there's not anything necessarily wrong with that proximal stability for distal mobility or these kind of conscious strategies. But the place it falls short is that's the end all be all, when really it should be a transition to this kind of more natural control gradient that we've talked about this whole time. Ryan, anything else briefly to add to that? We're already a couple minutes over, but.
Yeah, I think generally the question we get asked is okay, and people kind of, I suppose, misinterpret what we're trying to say sometimes, in that we're not saying that we want movement to be very subconscious in nature. We're not saying that we don't want movement to be conscious and more subconscious, but we have to recognize where. The key word is, where do we want more conscious awareness, and where do we want more subconscious awareness? Because the ability of me to distribute more conscious awareness through the distal endpoint, the hand and the foot, creates an environment whereby everything proximal has the opportunity to take on more of a subconscious, more self-regulatory role. So just to give you one more example, because I think this one really helps. If I'm reaching for my bottle here, right? When I reach for that bottle, I don't want to consciously think about what my shoulder's doing, what my elbow's doing, what my neck's doing. I want to generate an intention through the distal endpoint. My ability to trust that limb, that hand, to be able to reach and grab that target of interest allows for everything proximal to be more subconscious. Whereas if I had shoulder pain, for example, when I reach for something, I'm probably going to be thinking about what my shoulder is doing. I'm probably going to be thinking, oh, my physical therapist said retract and then reach, right? So all these, and that's what we mean about maybe those consciously driven strategies might be helpful in the short term, but we need to ultimately allow for that distribution of conscious awareness towards the distal endpoint. And again, we obviously need to use assessments to identify their capacity to do that. We can use their pain experience as a way to identify that. If somebody has a pain experience proximally, we already know that they are distributing more conscious control through those proximal tissues. And if we have this big picture focus where we ultimately want the hand based on the neurological communication with the system, we know that we want the hand, we know that we want the foot to be able to handle stress in a real world environment where it's more uncertain, more unpredictable. So if I have too much conscious awareness here, that's going to reduce my capacity to allow for that distal to proximal load distribution. And I might have more protective tone here. But if as a therapist, I'm narrowing my focus around the shoulder, so when I have shoulder pain, I'm trying to do lots of scapular retraction or periscapular strengthening, my eyes, T's and Y's, and I'm actually not looking at how that shoulder fits within the context of the entire gradient of control throughout the limb and the rib cage and the midline, then I'm going to not do a disservice, but I might not be able to facilitate the robust movement qualities that I actually want to facilitate. And so in powerlifters, again, it's just about giving them the experience of a different control strategy. Because I'm not going to say to them, okay, I want you to start breathing while you're lifting 600, 700 pounds off the floor, but I actually want to recognize, okay, that's a strategy that they're using. Maybe their inability to not use that strategy might be creating maybe a pain experience, maybe an increase in protective tone that's not able to relax. And so I want to give their nervous system the experience of a different strategy. And maybe they might implement that into their recovery strategies. Because again, like Kyle said originally, we don't want them using these force generating strategies to walk up the stairs, to walk down the street, to walk, if they're trying to tighten up everything proximally, to do things that shouldn't require a lot of proximal stiffening, then that's going to be very, very energy expensive. And that's key. So one of the key things is understanding how does the interaction between the neurology and our anatomy influence the energetic efficiency of your strategies, because all our movement should be orientated around trying to make them as energy efficient as possible, because that's going to allow me to have a greater bandwidth of resources to manage other unpredictable stressors. Whereas if I'm using lots of high threshold strategies to express movement that should be low threshold, then that's a mismatch there, and that's going to be very energy expensive. And that's something that needs to be considered in the context of pain and movement capacity issues as well.
Yeah, perfect. I think a lot of kind of the next steps for people's thought process is, how do you actually continue to create interventions to leverage some of these things? And if you guys are interested in more than that, we're purposely, because we've had so many questions about that, creating a course just on long duration isometrics. It's going to be a course we're having on December 13th. It'll be live, so we'll be able to take some questions. It'll also be recorded for anyone who purchases. If you guys are interested in diving deeper into this topic and starting to get more of those practical strategies to be able to leverage this distal to proximal concept, that's probably a great place to start. So that's on our website now. If you follow us on IG, Instagram, it's in the link in our bio as well. We just posted about it. So highly recommend going to check that out. That'll probably be a fun one. We want to try to have that be as interactive as possible. But that's open for registration now. So if you want to kind of take this idea to the next step, hopefully we'll see you guys there. But we appreciate you guys taking time out on your Sunday. I know we love to chat, so we can always go over a little bit. If you guys are watching on the replay, feel free to reach out to us with any questions, as always, right? Comment on our post, shoot us a DM, shoot us an email, contact us page on our website. We're always looking to help everyone just become more educated on kind of bridging that gap between neurology and anatomy. So again, thank you guys for watching, and we'll see you guys on the next roundtable or next course.